Hey, Fabio.
Hey boss, what's
What are
going
you
on?
up to?
So we learned about candidates or how to pick the people that are good for neurostimulation. Maybe we should go one by one now.
Let's do it. Let's learn
Yeah.
about VNS.
Okay. Dr.
All
Fisher,
right.
welcome back.
It's good to be back.
I will, in each of these brief 5 talks, show my disclosures, but I won't go through them in any detail.
We're going to talk about the vagus nerve, the 10th cranial nerve, and stimulating it to reduce seizures. You may wonder if you've thought about this at all. Why do we stimulate the left side? And the reason is because the left has more afferents to the brain. The right has relatively more efferents to viscera, but they both have a lot of afferents and efferents, which makes me realize that what happens in Vegas doesn't stay in Vegas. This this goes back a long way. This is a copy of an article from 1883.
What?
In the 1880s, there was a theory that seizures resulted from too much blood flow because the face was flushed and the carotid pulse was bounding. So they attempted carotid compression to stop seizures. And then a neurologist, Corning, used transcutaneous electrical stimulation of the vagus nerve, which we still try today, to reduce the pulse and the cerebral blood flow. So he had something that probably worked, although for the wrong reason. Then back in 1952, Zanchetti and his colleagues, including the great Maruzzi of Maruzzi and Magoon, reticular activating system, stimulated the vagus nerve to stop strychnine, a convulsant drug, induce seizures in cats. And you can see the bursts of spikes that go away with the bar, which is when the vagus nerve was stimulated. Then this was followed up by work in dogs. These are not dogs. The
Those are
dog
not
was
dogs.
in the experiment here. Again, strychnine and sensors, EMG sensors on the leg of the dog showing the seizure. And look how it stops as soon as the stimulation goes on. This is Jake Sabara, one of the pioneers in VNS. The first human trials were done led by Kiffin Penry and Dean, um, starting in November of 1988 in 3 centers, Bowman Gray, which was Kiffin's, University of Miami and University of Florida. And I wanted to point out that the first 2 patients at Bowman Gray became completely seizure-free with
Hmm.
vagus nerve stimulation. So for those of you again, deciding that you're going to get into clinical trials, consider that your best results may be your first 2 patients, and you may only ruin them subsequently by adding a control group.
For these early papers, did they use the same parameters we use for VNS today, or they were a little bit different?
No, they're the same.
Yeah. Okay.
Yeah,
How did
and
they get
they
those
used
parameters?
intermittent stimulation because the vagus nerve devices were built mostly by cardiologists who were used to intermittent
Hmm.
cardiac treatments, and that's carried down really to today with the odd historical distinction that epilepsy neuromodulation is usually intermittent, whereas movement disorder modulation is usually continuous. There's no real reason for the difference on that. When I got involved, we were still at a stage where we were a bit afraid that continuous stimulation would overstimulate the nerves, cause calcium influx, apoptosis, cause injury. So we made it intermittent. We also noted from some rodent experiments by Dixon Woodbury that the effective stimulation lasted about 10 minutes. So we figured if we stimulated for once 30 seconds out of every 5 minutes, then we could save battery life. And if you care about why we started out being intermittent, that was why. But now almost all of neuromodulation for epilepsy has imitated that intermittent cycling.
But I guess if the first thing tried is just still used, I get how much, effort to optimize has been done, and is it I mean, it doesn't seem likely that the first guess would be just the best idea, or
Yeah,
or
it depends
yeah,
how good the guesser was.
I guess that's
Since
true.
uh, the guesses were better than you would expect, but
Yeah.
it would be better if there were a lot more animal experimentation,
Mm.
figuring out the parameters, then going to human experimentation.
Hmm.
Irving Cooper, whom I mentioned earlier, started with humans, and um, some of us said, "Well, it looks like this works. Why don't we go back into the lab and try a few rats and see if we can figure it out?" It
Hmm.
would be better to go in the other direction again for you young possible researchers. There have been, more pertinent to your question, though, there have rather recently been some papers, some of which use machine intelligence to optimize data from multiple reviews rather than the laborious structured review. These are some things I know you a lot about, Dr. Westover, that, for example, show that for the most part we've been stimulating on the low side for VNS, that patients often do better if you get above 2 milliamps. I'll
Okay.
mention that a bit more later.
Yeah.
But it's just impossible to test all the parameters and combinations. So
Hmm.
these were the two pivotal trials. Interesting thing about the FDA is they only require two pivotal trials for drugs, but they may only require one pivotal trial for devices. Sometimes they require two.
Hmm.
So for VNS, they required two. For RNS and DBS, they only required one. I guess it depends upon how much they're convinced.
Hmm.
In any event, the first trial by Eleanor Ben Menachem showed 30.9% mean seizure reduction with stimulation versus 11% at placebo, significant. And the FDA made them do a second one, which showed about 28% versus 15%. Not a huge numerical difference, but still both significant. So it got approved. As an aside, it's interesting that you can't have a true placebo group for the VNS because the patients feel it in their throat. So there was a high and a low stimulation group, which might have blunted the difference between the two if there's any effect of low stimulation. RNS and DBS are not usually perceived by the patient, so you can have a true placebo for those.
Looks like the trend is promising. Can you just do super high and get even more benefit, or is there a limit they're running up into?
The machine goes up to the 3+ milliamp range, but it does seem like if it's tolerated by side effects in the throat,
Yeah.
going up to 2.5 is more effective
Hmm.
than the usual 1.5 that many of us used as our target
Yeah.
before.
And this would be capturing only like a decrease in number of seizures, right? Or I get, in a given time period, it would does it all, I assume, is there also some effect in on like, intensity of seizures, or however you would measure that?
Yeah, that's generally not um, ever listed as a primary outcome variable.
Right.
When you design a trial for the FDA, you have to commit in advance to what your primary
Yeah.
make or break outcome is going to be, and then you can have several secondary outcomes, which includes reduction of particular seizure types. But um, the companies generally ask the statistician to power the trial for the lowest number of entrants that will get the darn thing approved. And if you start powering it for subgroups, you
Yeah.
start increasing the needed sample size by hundreds.
Sure.
I mentioned that efficacy improves over the long term, and you can see that here, systematic review of like almost 3,000 patients, a 55% reduction responder rate, which means seizures cut in half or better, is increasing over years. When I say no control for dropouts, in most of these studies, they didn't control for people who said this is not working and they got out. So you can see the numbers decreasing, and of course the people remaining are doing better. But with the DBS and the RNS follow-ups, as I mentioned, those controls were put in place.
Mhm.
So here's another real-world trial showing that vagus nerve stimulation plus best medical practice reduces seizures a lot faster in the blue line than just best medical practice alone. And this looks great, showing the efficacy. It also shows the benefit of compressing your y-axis because here's what it looks like on a full-scale drawing. In California, I participated in a study that showed that rehospitalization rate was lower with vagus nerve stimulation, and it does have economic benefits as well. The adverse events with VNS are mostly in the throat, mostly voice alteration, coughing, pharyngitis, dyspnea, a few other things, occasionally site infection. These usually don't happen too much. If you increase the VNS slowly over time, I'll say what that is in a minute or two. But I do have the patients sit around in the waiting area for 30 minutes every time I make an increase. Hoarseness declines over tenfold by year 3. But Fabio is wearing a shirt that has a girlfather on it, like the Godfather movie. And VNS makes you talk like the Godfather every time it comes on. I can always tell when it comes on. 30 seconds on and 5-minute off, typical cycle with a patient in clinic. One more serious problem is exacerbating obstructive sleep apnea by the downstream influence of the vagus nerve. It does slow the heart rate a bit, and it does affect respiration. It's unclear how often this occurs, but sometimes when it does occur, it may be a type of apnea for which CPAP does not help. Original vagus nerve stimulation was 30 seconds on, 5 minutes off. And the patients were given a magnet that they could swipe across the chest to start stimulation mid-cycle if they felt a seizure coming on and they weren't immobilized by the seizure. They didn't have to use the magnet, but they could. And the FDA requires that the patients always be able to turn these devices off if they're having a problem. So the magnet was given a dual function. If you swipe it, it turns the stimulator on. If you hold the magnet over the device or paper tape it over the device for 30 seconds or more, it shuts the VNS cycling off. And short reductions, probably even a few days, don't seem to have much of an effect on seizures. So if, let's say, someone were making an important phone call and they didn't want to go hoarse during the phone call, they might turn it off. Then when you take the magnet away, it automatically starts the cycling again. So some smart person working for the company, not me, said, hey, there's tachycardia with a lot of seizures, true, about 75, 80% of them, in fact. Sometimes bradycardia, but usually tachycardia. And this device is implanted in the chest, right next to the heart, can pick up heart rate pretty easily. So, what if every time the heart rate went up a certain specified amount, it would stimulate? So that was the tachycardia triggered VNS trial that I led, and it behaved. It came on when it should. sometimes seem to stop seizures.
Mhm.
The trial honestly really didn't show that it was better than the older way of doing it, just that it worked as uh, as expected. Some subsequent small series have indicated that patients who don't respond that well to 5-minute cycles have shown improvement when they had a tachycardia sensor. And you may say, well, it's going to come on when you run up the stairs. Usually true, although the algorithm um, looks for a faster rise rate typically than with most exercise.
Hmm.
Uh, but it doesn't matter if it comes on more often. It just shortens the battery life, maybe 10 to 20% if it comes on a lot. So this is the device that's most often used now, most often implanted. Depression in VNS has this as a beneficial side effect. It's a nice side effect because so many of our refractory epilepsy patients have depression.
What's the effect
It's
size there for depression, roughly? Looks like.
those are
Okay.
depression scales, various
Okay,
depression scales that you're looking at, and
I see.
at low, medium, and high stimulation.
And
There's
this is relative to placebo? Like is placebo zero?
placebo is usually a baseline measurement of depression.
Oh, okay. I see. So these are like so okay. So you could get a 10% of patients remit at 22 weeks with the high stim.
Right.
About. Yeah. Okay.
And there wasn't compared to baseline remission in those
Yeah.
patients beforehand with whatever treatment they were getting.
Yeah. Yeah.
It's only indicated for focal, then called partial seizures with or without secondary generalization, originally in adults, now down to age 4. But it's used off-label a moderate amount now with patients with generalized seizures, including Lennox-Gastaut or other generalized seizures when medications have failed. So you see median reductions um, for different modes of seizures, focal, generalized, all seizures. This is focal. The orange is generalized. The green is all seizures up to 2 years.
The effect is really early and it kind of stays stable up to 2 years. Is that fair to say?
Yes.
It doesn't really improve too much as time goes on, in this case at least, seems like.
Yeah, so that's a little counter to what I said before in this particular study, but that's what that graph shows. So we were talking before about optimizing, and here you can see suggested target range instead of up to 1.5 or from 1.5 to 2.25, generally if they're not having disabling throat symptoms.
Yeah.
And these seem to be the best parameters, 250 microseconds as opposed to the 500 microsecond pulse width and 20 hertz as the stimulation frequency. So the device looks like this, just to get very practical. This is the implant that goes subcutaneously in the chest. Of course, everything for all neurostimulators since the earliest days is entirely subcutaneous or they would get infected. Then you have a programming paddle and you have a controller of some type that can program it. So it's non-invasive programming for all of the neurostimulation modules. And with the VNS, you have the normal mode, which is cycling, typically 30 seconds on, 5 minutes off, but you can change that to more rapid cycling. Runs the battery down faster if you do. Battery usually lasts well over 5 years, maybe 10 years, but if you do rapid cycling or high currents, it may only last a couple of years. And when it gets replaced, you don't have to replace the wrap around the nerve part. You just have to do the chest part and plug in the new device. So when we say battery replacement, since it's a sealed battery, it's really a stimulator. replacement with a battery inside.
Mhm.
So you got the normal, then you've got the auto stimulation, which is the tachycardia sensing, which you can set to go on when the heart rate has a moving 10-second window, increase of 20%, 30%, 40, 50, 60, or 70% over the previous windows. How do you know what to set? We start with 30% just as a guess, but if you look at some seizures from previous EEG recordings, ambulatories, or epilepsy monitoring unit recordings, you can see how much the patient's heart rate increases and tailor it to that. And then it comes on to that amount. And then you still can do the magnet swipe, the hand swipe across to start in the middle. We typically set the auto stim higher than the normal cycling and the magnet higher than the auto stim cycling. It's not a requirement, but it makes some sense.
Let's say you have a fresh device and you're up titrating the parameters in clinic. Do you usually start with the current output going up to at least 1.5? And then once you reach that target, which parameter do you pick next and next? So what's your algorithm that you use?
Yeah, so I will start with these parameters.
Mhm.
The duty cycle is calculated, so you don't have to set that.
Sure.
I'll start with 0.25 milliamps. The device will get tested in the operating room, not so much by the surgeon, usually the company rep or some poor fellow is in there testing it to make sure it works. But we leave it off for the first month or so to allow healing, just so any side effects can be separated from post-operative side effects versus stimulation side effects. Then we'll have them come into clinic and have it on at 0.25 milliamps. Then schedule return visits at about 3-month intervals to turn it up, and you'll see the cycle, but 0.5, 0.75. And ultimately, I would say to get it up to 1.5, I'm now saying to get it up to 2 to 2.5 if possible. There is a option to schedule at steps that you choose for increases at home. And this is valuable for the patient who lives hours away. You can just, even at the very first or second visit, program it to go up at automatic intervals so they don't have to come in just to see the programmer paddle and have it increased there.
And primarily, you're really just changing that one number, right?
Usually, I
Yeah.
generally don't fool too much with these other numbers. If somebody is not responding well, and I've got the current as high as I feel comfortable doing, or they feel comfortable, then I start going to more rapid stimulation times, different settings. So may even be, the equivalent of 1 minute on, 3 minutes off. Doesn't use exact round times, but like that increases the duty cycle.
Mhm.
And if the patient already has, back to Dr. Westover's point, a DBS or an RNS or both, does it change your planning here on the VNS side?
No, maybe it should, but it doesn't.
Okay.
I have no reason to change it.
Okay.
So this points out how you can do scheduling of increases in the current, the auto stimulation, and the magnet when you want them, even what time of day you want them.
If you have somebody, and it actually happened to me a while back, who's diagnosed with OSA with a VNS, do you typically turn it off for the entirety of the night to prevent worsening of the OSA?
A very good question. I would certainly, if you know about that, I would turn it down, maybe turn it off, or not use it at all, because OSA can be pretty serious, especially if it's OSA that doesn't seem to be responding to CPAP in the patient. I have this here for MRIs. You can get MRIs, but you don't want to do it directly over the device, which means that you have a limitation with cervical MRIs. And you should turn the device off or in a special MRI mode, and you should have your MRI people read the requirements for the MRI before you do it, but you can get an MRI. And if these devices don't work, you can remove them. These days, we don't advise the surgeon to remove the wire that's corkscrewed around the vagus nerve because there's too much risk of stretching the vagus nerve. It often has fibrosis around it, but just to clip the wire, not the nerve, and take it and the stimulator out. And then there's no longer a limitation to MRI, so long as the length of the wire is less than 2 centimeters across the nerve.
And the risk, if it were longer, is overheating or
Heating
yeah.
and maybe burning the nerve.
Yeah.
One of the complications, which I've only had in 100 plus VNS patients, is stretching the vagus nerve and its recurrent laryngeal branch, and then you can get a unilateral vocal cord paralysis. It usually heals over 6 to 12 months, but the patient again sounds like the Godfather that period of time. So I joke, but it's no joke to them.
Yeah.
No limits to a CT scan, by the way, for something like a cervical spine. So these are the practical issues. Turn the current up slowly from 0.25 to 0.225 if you can get it up there. Honestly, when someone's very tolerant of this, I may skip a step. I watch them in clinic. As soon as I turn it on, I'm usually greeted by a few coughs and a very hoarse voice. I'll send them to the waiting area, which will take them through a few cycles and make sure that it's not too uncomfortable for them. If it is, I turn it back down again. Otherwise, I send them home. Increase every few weeks. Auto program if you want. Get an MRI. With removal, leave the wire wrapped around the vagus. There's rare vocal cord paralysis. And just let the patient know that it's going to take some time before it makes their seizures better, and it doesn't make everyone better.
We talked about using VNS for generalized seizures, and you brought up the Lennox-Gastaut syndrome case. What about just the IGEs or genetic generalized epilepsies? What's your take on using VNS for those patients?
I think it works. There hasn't been a large randomized blinded trial, but there are several trials strongly suggestive, in my view, that it causes some benefits for idiopathic generalized epilepsies as well. That is off-label.
Yeah. When you quote to a patient, considering this, the chances of a benefit and the magnitude of benefit, what do you say?
Probably the most cogent thing I say is that more than half the people feel that it's benefited enough that they want to keep it.
Mm-hmm. Okay.
That's understandable by the patients, but it's a little bit more clear than saying more than half the people are responders or talk to them about statistics.
Yeah.
But I also tell them that it's not likely to be a cure. It's not likely to make them seizure free. It's unlikely that it will let them get off all of their seizure medications.
Mm-hmm.
But there's a good chance after a while, the seizures may be fewer in number, less strong,
Mm-hmm.
less long lasting, quicker recovery, that it's possible to reduce the anti-seizure medications. And that they like a lot.
And do you
By the
find
time patients turn to neuromodulation, they're usually pretty down on
yeah.
seizure medication.
What do you think about VNS for absence seizures, Dr. Fisher?
Oh, that's a good one. I don't think it's used very much for that. So in Lennox-Gastaut patients, they have atypical absence seizures as one of their seizure types. And although they're hard to count in the few clinical trials that have been done, they seem to decrease. But for typical absence, I don't think we would use it. I think that is mostly med responsive. And for atypical absence, we would also be looking at all the other seizure types they have. So we'd be using it for a variety of seizure types, not just that one.
Thank you, Dr. Fisher.
Wise words.